Okay, our next presentation is about treatment of women at risk of early onset hemolytic disease of the fetus by Dr. Ivonne Bedai, specialist obstetrics and gynecology, fetal medicine, pediatric and adolescents gynecology, maternal and fetal medicine, Mannheim University, Germany. Recorded video.
Ladies and gentlemen, dear colleagues, it's a pleasure for me to take part in this Congress. I'm very sad that for the second time I cannot be there in person, but I have to give my presentation from a distant place because of the pandemic. I hope very much that this gets different next year. My name is Ivonne Bedai. I'm working at Gießen University in Germany in prenatal medicine and fetal therapy, and it is my pleasure to give you this presentation. I'm going to share my screen now. I hope you can see and hear me well. So my talk is about the treatment options in women at risk for early onset haemolytic disease of the fetus and newborn, because we know that this is a particular risk group that is very difficult to treat. And that's why we focus on that topic in that presentation. So just for repetition, we know that there is an incompatibility between the mother and the fetus. Mother is negative for special erythrocyte antigens and the fetus is positive, so it comes to alloimmunization in pregnancy. There are physiologic fetal maternal bleeds in basically all pregnancies, so the mother gets exposed. This exposure gets more when pregnancy advances and during delivery, and then the mother is developing anti-fetal blood type antigen antibodies, and in a next pregnancy that can lead to a problem because of the placental transfer of anti-fetal blood type antibodies. As I told you before, there is a physiologic fetal maternal bleed, which is very minimal. It rises a little bit when pregnancy advances, but still it's very minimal. Also, alloimmunization can happen after miscarriage, DNC or different invasive procedures, also in placental abruption, or when fetal surgery is done. We have obviously a chance to prevent an NTD, but we don't have that chance in other antibodies. And there is also a chance for immunization in the non-pregnant period, mostly by blood transfusions or needle sharing. Fetal erythrocytes can be detected as early as 6 weeks of pregnancies in the maternal circulation, again in minimal amounts. And we have anti-D antigen that can be detected after 7 weeks on pregnancy of fetal erythrocytes. So different blood group antigens can be expected to be seen in different stages of pregnancies. And in particular, KEL and MNS are not only expressed on the fetal erythrocyte, but also on the hematopoietic precursor cells. So they may lead not just to a hemolytic anemia, but also they make the proliferation and new building of erythrocytes difficult and can be more pronounced and also lead to additional thrombocytopenia, complicating the situation. The Igg transport from the mother to the fetus is done via active transport, which is Fc receptor related. And you can see on the left-hand side the maternal circulation. So the IgG, not just for blood group antigens, but also different antigens that are needed for the protection of the fetus, are entering the fetal circulation via this active transport. For these IgG, it starts in late first trimester at around 13 weeks of pregnancy, which is quite early. And you can see that it's also linked to the pH. So they bind very well, or they bind very well at an acid pH, and then they are dismissed into maternal circulation at a pH of around 7.4. We have a lot of different red cell surface antigens that can be found, but just a minimal number of them makes considerable problems, mostly NTD, which we can prevent via the prophylaxis, and then we have the CAL that are more difficult because we cannot prevent them, and also they tend to make problems that are not that very much linked to a special titer, and also they affect the building of the red cells, so they can cause serious problems. Others are mostly anti-small c and anti-E, and as you can appreciate in the following slide, which is too much to go through to it, but you can appreciate there is a humongous number of antigenes that are on the erythrocyte. Just a minimal number of them cause problems. It's just your orientation that you can find very different antigenes. And around 15%, the Caucasians are rhesus negative. It's different in different ethnicities. And before we had the chance for NTD prophylaxis, the risk of immunization was about 16%. And despite pre and postnatal NTD prophylaxis, about 1 in 1,000 women will develop NTD or will develop alloimmunization. And as I told you before, there is no existing prophylaxis for other antigens like CAL, small c, Duffy, and many others. What happens if the fetus gets anemic? So in a severe case of fetal anemia, the fetal is developing fetal hydrops, and it depends very much also on the grade of fetal hydrops, but prognosis can be very limited in these advanced cases. They can also happen that there can also have neonatal thrombocytopenia, cholestasis, and jaundice, and there may also be neurodevelopmental impairment in these cases, mostly in severe cases. And still there is a fetal and neonatal mortality that it's dropping with the fetal treatment and prevention, but still it's existing. What can we offer as a treatment if you find the fetus to be anemic? Intrauterine blood transfusion is the treatment of choice. And when a baby is born, you have the transfer phototherapy, neonatal transfusion, and also in severe cases, also with kernicterus, to prevent kernicterus, you go for exchange transfusions. But these kind of complications you want to limit. We know that there is a very routine surveillance of women at risk. So you screen them in early first trimester, or in first trimester, you look for the antibody titers. And if you find antibodies, you refer to a maternal fetal medicine specialist or center, and then they get control. And when the titers reach a critical level where you may suspect that anemia can happen, then you're going to surveillance with the measurement of the the cerebral arteria cerebri media. And the levels are different for different antigenes. For example, anti-D, it's around 1 in 32, but for CAL, it can be much less and much less predictable. So it's more difficult to control. As I told you already, the anemia that is associated with anti-CAL antibodies is much more unpredictable. This is for the onset and also for severity, because these antibodies cause both red blood cell destruction and also the suppression of fetal erythropoiesis. And this is different than in the anti-D situation. And you have to remember that the immune system has a memory. So if you had a problem, you tend to have the problem again because you have an efficient immune response, and the haemolytic disease of the fetus and newborn is expected to occur earlier and with increased severity. So this is the group we tend to focus with the prevention, to postpone these situations to a later stage of pregnancy, because it's difficult to handle, and obviously the morbidity and mortality is more pronounced. This is just a sum up about the things I told you, how to proceed in a case of fetuses at risk. And then I highlighted the fetal therapy, which is for sure the intrauterine transfusion, but there's also a maternal therapy you may use as a treatment or prevention. This is the use of intravenous immunoglobulins, plasma exchange, and this is what we want to talk about, the use of monoclonal antibodies, which is still used in a research setting. This is also not new. What do we do in fetuses at risk that pass a critical level? So we go to control the maximal velocity in the middle cerebral artery, and if it passes 1.5 mom, then we should confirm or go on fetal blood sampling to confirm the suspicion of anemia. And in case that fetal anemia is present, we go for blood transfusion. The sensitivity of this approach is very high, reported to be 100%, with a false positive rate of around 12%. So not all of the fetuses we detect as at risk are really affected. This is the table from the publication of Mari, where you can see the different levels of hemoglobin and the levels of moms, which is more highlighted in this graph, where you can see the different levels of anemia ranging between mild, moderate, and severe, and the corresponding moms of hemoglobin. And you see the colored dots are the ones that developed hydrops. So hemoglobin levels are quite low in these cases normally. So this is a picture of a fetal hydrops, which normally presents with a tensed ascites. Like in this case, you can also see that the heart gets bigger and the fetus develops cardiomegaly, starting as a method of compensation also. And when it comes to fetal treatment, you have different ways how intrauterine transfusion can be done. You have two main or preferred areas. One is the placental cord insertion, but you have to be aware that if you pass the placenta in that way, it may lead to the formation of new red blood cell antibodies or to sensitization. And then you can use the intrahepatic umbilical vein. In special conditions, you can use, you can give the transfusion intraperitoneal. This can be added to the intrahepatic umbilical vein transfusion, or you use it in early transfusions, and very seldomly in cases that are very early or with a very high BMI where you have very difficult conditions, you can also do the blood transfusion intracardial. We know that special situations lead to a higher rate of complications, so you should avoid arterial puncture. The transfusion should always be done in the vein. In case of free loop needling, meaning that you pass the amniotic fluid to get to a free loop of the umbilical cord, you have a higher complication rate. You should always try to use fetal paralysis because that enhances or gives better results, and you should always have an experienced operator on board because these are the factors that influence complication rates. So in experienced hands, it's a safe and routine procedure these days, 80 to 97% survival with adequate prenatal therapy, and the perinatal loss rate, or the procedure-related loss rate, is 1.8% per fetus and 0.6% per procedure, and it depends very much on gestational age and the operator experience. But, and this is about the topic we talk, the risk is markedly increased before 20 to 22 weeks, so early need for transfusion has a much higher rate of complications, and you can see that the procedure-related loss rate is, or complication rate is 5 to 6.7%, and the perinatal loss rate in these complicated early cases is up to 20 to 24%, which is much higher than that I just showed you. So the aim is, if you had a fetus at risk, or if you have a fetus at risk, mostly these are cases where the mother has, or the fetus has suffered in a previous pregnancy, also haemolytic disease of the fetus and newborn. So you tend to develop that again, and you tend to develop that earlier and more severe. So this is the group of people that we focus in this preventive group. And so we try to prevent and delay this early onset problem. Again, the graph with the transport of IgG, what can we do to prevent? So the idea could be an early blocking or competition on this FC receptor just to diminish the transplacental Igg transport, or you may dilute the Igg, or you decrease the recycling in order to have less Igg in these at-risk pregnancies. So these are different options you may think of in this special situation to prevent. There was the Petite study, which is standing for postponing early intrauterine transfusion with intravenous immunoglobulin treatment. So they gave IVIG to the mothers in order to postpone fetal anemia. So they could show a later development of fetal anemia in all cases of around 15 days later in comparison to the previous pregnancy, which is good because normally you expect them to happen much earlier. And what they have seen also, if you start early before 13 weeks gestational age, the haemolytic disease developed on average 5 days later, and they had 31% less frequent before 20 weeks. They had a reduced rate of fetal hydrops and less need for exchange transfusion after birth. So it seems important that you start early in pregnancy to get the best results. Another way of treating could be with monoclonal antibodies. This is the Unity study where you use nipocalimab or M281 in order to block these FC receptors. Let me show you that in a minute. So M281 or nipocalimab is a next generation FC receptor blocking recombinant monoclonal antibody. It has over 1,000 times higher affinity to the FC receptor than IgG, and it shows relatively quick inhibition of the IgG transfer. And you can find it in the maternal circulation, but not that much in the fetal circulation. You may fear that when you have like more less recycling and you don't pass IgG to the fetus, you obviously block also the IgG transport of protecting IgGs, and you may fear a rate of infection in the mother and also in the fetus, but it was not that very much, or it was not significantly different from placebo. Here's a graph where it shows how this M281 competes with IgG at the FC receptor and how the immunoglobulin is not transported to the fetus, and also recycling is diminished. So you can show a diminished rate of IgG that is passing to the fetus, causing problem. It blocks the IgG on the side on the FC receptor, binding with a very high affinity, not just at an acid pH, but also at the pH of 7.4. It's distant from the albumin binding site, which is also linked to the FC receptor, and it blocks the IgG recycling and facilitates the IgG catabolism, as I have told you already. And it has no effect on other immunoglobulins like IgM, IgA, or IgE, and it's not affecting the cellular response to the immunization. Who can enter the study? Because obviously this drug is applied under study condition and there's a big worldwide study going on. Obviously, this is not all the criteria, but I just focus on the main criteria. So you have to be 18 years or older. You have to have a singleton pregnancy between 8 and 14 weeks. This is normally the time for recruitment. Previous pregnancy with one of the following conditions that has happened prior to 24 weeks of gestation, so very early. Severe fetal anemia, defined by hemoglobin less than 0.55 mom for gestational age, which is taken out of the table of Murray. Fetal hydrops with peak systolic velocity at or over 1.5 mom. Stillbirths with fetal or placental pathology, indicative of hemolytic disease of the fetus and newborn. You have to have titers at risk. This is for NTD, 1 in 32, and for anti-cal, 1 in 4. The study is just carried out with these two types, and the fetus must be shown to be at risk, must be shown to be positive by free fetal DNA testing. So the primary objects are to evaluate the safety in mother and neonate infant of nipocalimab or M281 that is administered to the pregnant women at risk for early onset severe hemolytic disease of the fetus, as I have showed you already. And this is difficult to recruit this very small group of people who had a problem before 24 weeks of pregnancy. And secondly, to evaluate the efficiency of nipocalimab as measured by the proportion of patients with birth at or after gestational age 32 without intrauterine blood transfusion through their entire pregnancy. So it's a quite long study. The total time on study will be approximately 50 weeks for each pregnant woman, because you get recruited, you have to fulfill a high number of different issues, and then you're entered into the treatment group, which is the administration of nipocalimab weekly, and then you are followed up to see if you and the fetus are doing well. So and the fetal follow-up will be, or the fetal and neonatal follow-up will be 96 weeks for each child that is born during the study. The study includes a maternal screening period of up to 6 weeks and a treatment period of around 20 weeks, and then a 20-week postnatal follow-up for the mothers and a 96-week follow-up period for all neonates and infants. This is the timeline and how it's going to happen step by step, just on a graph for your information. And there are several centers in the world. Most probably there's also a center in your close proximity, which you can contact in case that you have a patient at risk. The study is paid for these patients. It does not mean that they get money, but if they have travel expenses because the next center is not close to them, or if they have to stay in the hotel, the company covers that, so should not be a limit to take part. And here you can appreciate the centers that are participating in the study. And I thank you very much for your attention. If you have any questions, or if you have any patients that may enter into the study, feel free to contact me on this email address. I'm very happy to answer your questions, and I'm more than happy to help you to include your patients in this study. Thank you very much for your attention, and have a nice Congress.